Good afternoon, everybody. It's Dirk Huyer speaking, a task force member, and also I have the additional honor of being a work stream lead for the clinical guidance and surveillance work stream reporting into the task force. And I'm joined with well-known Dr. Barbara Yaffe, and then I'd like to introduce Dr. Smith, who's over my shoulder on a TV. Dr. Smith is in London, Ontario, and he has kindly joined us to take us through the ethical framework. Dr. Smith, Maxwell Smith, is a bioethicist and assistant professor in the Faculty of Health Sciences at Western University. He is a consulting clinical bioethicist at Sunnybrook Health Sciences Centre, and he also is an assistant professor at University of Toronto. He does have specific and area of expertise and research interest in public health ethics, with a specific focus on ethical dimensions in the pursuit of health equity. He is a member of the COVID-19 vaccine distribution task force, and he's also working directly together with me as the co-chair of the prioritization subgroup work stream, which also reports up to the task force. It's an honor to be working together with Dr. Smith, and it's always a pleasure to be, and an honor to be with Dr. Yaffe again. And we haven't been together for a while, so happy to be here together. And I'm going to pass over to Dr. Smith, who's going to take you through the ethical framework, which has been prepared with input from many, and the task force has adopted and shared, and we are releasing this publicly, and will be available for people to review, and will guide us through the next number of months. Dr. Smith.
Thanks very much, Dr. Huyer. So, as Dr. Huyer mentioned, the task force has committed to using an ethical framework to best ensure that our vaccine distribution and prioritization recommendations are of the highest ethical quality. Now, I think it's important to note at the outset that ethical frameworks themselves don't necessarily directly provide answers, such as which groups to prioritize for vaccination, but rather they articulate a set of ethical considerations and ethical commitments that will guide our recommendations and decisions in the coming weeks and months. You'll often hear General Huyer and others say that we'll distribute vaccines in an equitable and fair manner, and our ethical framework really explains what we're committing ourselves to when we invoke these in inherently ethical terms. So our ethical framework consists of 6 key guiding principles, which, when used to inform vaccine distribution decisions, they aim to enhance the consistency in our decision-making, the stewardship of these precious resources, accountability, as well as public trust. The 6 key ethical principles in the framework include minimizing harms and maximizing benefits, equity, fairness, transparency, legitimacy, and public trust. And I'll walk through each of these briefly now. So the guiding principle of minimizing harms and maximizing benefits commits us to using available vaccines such that they reduce overall illness and death related to COVID-19, and particularly protect those at greatest risk of serious illness and death due to biological, social, geographical, and occupational factors. So this is why in this first phase of vaccine rollout, vaccines are going to the most vulnerable groups in our society, including those that are living and working in long-term care homes. Aiming to use available vaccines to minimize harms and maximize benefits also requires that we aim to protect critical infrastructure and promote social and economic well-being. We've, of course, committed to an equitable distribution of vaccines. So this means that we'll aim to not create and, in fact, actively work to reduce disparities that are related to COVID-19, including disparities in the social conditions that are linked to increased risk of illness and death related to COVID-19. Critically, this involves ensuring that those who experience greater burdens or those who are at risk of experiencing greater burdens from COVID-19 are at the forefront of our minds when making recommendations. In addition, equity fundamentally commits us to respecting the equal moral status and human rights of all individuals, and to distribute vaccines without stigma, without bias or discrimination. And in fact, our ethical framework emphasizes the legal obligations that exist to take preventative steps to stop the spread of COVID-19 and treat people without discrimination, and to ensure that vaccine distribution and prioritization decisions comply with existing human rights protections. The third guiding principle in our framework is fairness. Among other things, this commits us to ensuring that every individual within equally prioritized groups has an equal opportunity to be vaccinated. so that some groups don't experience avoidable barriers to accessing the vaccine when they have been prioritized. Fairness also requires that we ensure that jurisdictional ambiguity, like if there were ambiguity regarding jurisdictional responsibility between federal, provincial, or municipal governments regarding the vaccination of certain populations in Ontario, like First Nations populations, doesn't interfere with vaccine distribution. So we're making sure that people are getting the vaccine when they need it. So here we invoke Jordan's principle, which is used in Canada to ensure that First Nations children living on and off reserve have equitable access to all government-funded public services. And fairness also requires inclusive, consistent, and culturally safe and appropriate processes of decision-making, implementation of our plan, as well as communications about the plan and the rationale for the decisions we're making. A fourth guiding principle is, no surprise, is transparency. This is something that's crucial for public trust. This guiding principle requires that the plans for COVID-19 vaccine prioritization and distribution, as well as the underlying principles and rationale for those plans, are clear, that they're understandable, and that they're communicated publicly. And finally, we've committed to ensuring that our recommendations and decisions regarding vaccine distribution are seen as legitimate by committing to grounding these recommendations and decisions in the best available data, the principles that are outlined in our ethical framework, as well as from input from affected parties, including those that are historically underrepresented in decision-making. So if the work of our task force is not seen as legitimate, public confidence and trust in our work may be diminished. So we felt this is quite important. And so using these principles to guide our work together will help to promote the final cross-cutting guiding principle of our work, which is public trust, which we hold quite dear to the process of our recommendations and decision-making. And so by making this ethical framework public at this point, it's still December of 2020, we're putting the principle of transparency into action by explaining the key values and considerations that will guide vaccine distribution decisions. We also hope that this ethical framework will inform the work of others involved in the vaccine distribution rollout, say at regional or local levels, to ensure that all vaccine distribution decisions follow a consistent ethical approach. So I'll stop there. Thank you very much, and I'll hand it back to Dr. Huyer and Dr. Yaffe.
Thank you very much, Dr. Smith. I'm just, people may look at this and it's very, very principled. It's really well thought through. But some people may have some difficulty understanding how does that translate down to an operational perspective. So as an example, the prioritization subgroup, which is a group of 16 physicians and bioethicists who are trying to help to provide advice and recommendation to the task force about prioritization of populations or sequencing of populations to be vaccinated, have started to have discussions around healthcare workers, for example, because we know that decision has been made that there are 4 key groups that are going to be populations that are vaccinated during the period of time to approximately March, and those will be those seniors who live in congregate care settings where care is provided for seniors, and all of those who work in those settings. So it's the residents, it's the patients, it's the staff, and anybody who's an essential caregiver. So that's population number 1. Population number 2 is a very broad category of healthcare workers. Population number 3 is First Nation, Métis, and Inuit adults in Ontario. And population number 4 is those who are receiving home care on a chronic basis. And so all of those each have their own sub-prioritization or sub-populations within. And so we've done some early work to talk through developing a matrix which is applied to, for example, healthcare workers in hospitals, where we look at 3 things, which is the exposure risk, the transmission risk, and then the criticality. So how critical is that service to ensuring that there's effective healthcare resources? And so that will be applied and worked through to help to sequence populations within the healthcare field over the first phase of immunization. For example, paramedics, where would they fit in to that first phase, which is the phase that will occur over the first three months? And similarly, where would family doctors and primary care physicians fit in? Not to tell you where those will be, but those are topics because we're still figuring those things out. But that's an example of how the prioritized risk guidance will be utilized to really define and provide a view into how vaccination will occur. Now, having said that, there's also significant consideration of logistics. So which vaccines are available? How can those vaccines be provided? What is the number of those vaccines? And so those are the kinds of things that are also key components of thinking through how do we sequence, how do we deliver, and how do we provide the vaccination to those who are in the populations to be vaccinated. I think at that point, Dr. Yaffe, I don't know if you wanted to add anything at this point or if we'll open for questions.
No, let's just open for questions.
Perfect. So we'll take questions. Unless, Dr. Smith, you want to add anything else after that?
No, I think that's great. Thank you.
Thank you.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
And a reminder to press *1 if you do have a question. And your first question will be from Christina Tenelia at CP24.
Hi, doctor. Thank you so much for taking my question today. Dr. Smith, you talked about priority for the vaccine going to the most vulnerable groups. Dr. Huyer, you noted a list and a matrix, but you also noted in the framework for distribution that the priority should be given to those who experience or are likely to experience greater burdens due to COVID-19 in society. The framework document you have shared notes the Ontario Human Rights Commission's policy, and it also notes groups that include women and children facing domestic violence or abuse, people with disabilities, the LGBTQ community, workers in precarious employment, prisoners. But those groups, people in those groups, are nowhere listed formally in the first two phases of the vaccine rollout. So where do they fit in? And how does that fall into the equitable distribution of the vaccine?
Max, do you want to start with that, Dr. Smith?
No, I'd be happy to. So I think you're pointing to something really important that we wanted to highlight in the ethical framework itself, which is to say that we want to protect those populations who are most at risk, but not just due to biological factors, but also due to social factors, to geographical factors, and occupational factors. And so we wanted to build in the thinking that we can think about those that are at risk for other reasons other than just being high risk biologically. So I think, and as well as human rights concerns and other considerations that you've raised, these are all the considerations that need to be weighed. It's not terribly straightforward identifying the exact populations that those point to, but absolutely those are the sorts of considerations that the ethical framework requires us to think through. And I think, Dr. Huyer can speak to this, but these are the sorts of things that will continue to inform those priority groups in phase 2.
Yeah, absolutely. Thanks, Dr. Smith. So those are all considerations that we are now also talking about at the prioritization group and will be raised at the task force as those key examples of thinking about how does that population and that group and the vulnerabilities associated with them and other risks that are associated, as well as potential inequities, where do those all fit into the prioritization? And we are hoping to have additional information about a longer term view beyond the first 4 groups that I talked about. And we're working closely together with the task force and bring the sub-prioritization group to bring those to the task force in the next while.
Follow-up?
Thank you very much. My next question is about what has been called immunization task force. Previously, Health Minister Christine Elliott noted that vaccination or proof of vaccination may be required, per se, for travel, to go to a movie theater. I'm wondering, Dr. Smith, is that ethical, number one? And number two, does your group have any evidence that there are any industries, the travel industry, the entertainment industry, that plan to enforce this in any way?
So, Dr. Smith, if you take the first part, I'll take the second part.
Yeah, no, happy to. So, I mean, the idea of having an immunity passport or some sort of certification of vaccination certainly raises a lot of different ethical considerations. One of those considerations, of course, is, we want to make sure that we're identifying those that have been vaccinated for their first dose so that we can get them back for their second dose. It helps us to understand surveillance in terms of how much of the population actually has been vaccinated. But the extent to which that information would be used to limit services or other things, I think is an important question where you need to think about potential stigma and inequities that may emerge from that. And Dr. Huyer, you can speak to whether this question itself is within the remit of the task force work itself.
Yeah, I can't speak to whether it will be within the task force right now. I'm not aware of specific reach out. I certainly haven't seen any, but I can't speak for the whole task force. So it's not been a topic that's come to our prioritization group. But having said that, exactly as Dr. Smith said, we do need to have a good understanding of the vaccine uptake, understanding who's had it, and have a perspective from a health point of view to understand the degree of immunity that may arise from the vaccine. So all of those things are important things for the moment to think through how effective and what are the next months into years as far as the vaccine goes.
Next question.
From Kelly Botello at CHCH News. Please go ahead.
Good afternoon. Retired General Dirk Huyer said paramedics will have to wait until the spring for vaccines. Why aren't paramedics one of the first groups in line for vaccines like other essential healthcare workers?
So a few minutes ago, I did comment that the paramedics are within the healthcare field and will be within the first phase, which is extending to about March. So that's the plan. I can't speak specifically to what General Huyer was saying, but from my perspective, what we also know is that in the first phase, we're going for the most vulnerable folks first, and those are the long-term care home staff, residents, retirement home staff and residents, recognizing assisted living where people are of greater vulnerability and all of the staff that are working there. And then as we move through the first phase, there will be multiple populations that will be vaccinated at the same time. So paramedics may come at a different point with other folks that are in the healthcare field. All of that work will happen to some extent by logistics, but paramedics are recognized as an area of healthcare and are recognized as an area that will be vaccinated within the first grouping.
Follow-up.
Niagara Region has 35 paramedics self-isolating, which obviously puts a big strain on their service. Are situations like these taken into consideration when it comes to vaccine distribution?
So we take a variety of things into consideration. What we look for, and talked about that a little bit earlier, which is exposure to COVID for the particular person who's working in that situation, or the patient or the resident, and then the potential for transmission, and then the criticality. So all of those factors are important factors. So it really is both from a provincial perspective, then within a population, so the population of paramedics, and then within the region. And then after you look at the particular region, then within that paramedic group within the region, there may be some prioritization based upon age or based upon other factors that may put them at greater risk. So it's all of those pieces or considerations that are applied through the consideration of who would be vaccinated. And I don't know, Dr. Smith, if you want to add anything to that, or did I capture it effectively?
No, I think that's exactly right, Dr. Huyer. It's risk of exposure is a critically important dimension here when we're thinking about prioritization, and certainly paramedics, other emergency first response have a degree of exposure, high risk of exposure. We need to think about criticality in the patient populations they serve. And then, as Dr. Huyer mentioned, wanting to make sure that we're targeting those groups in regions that are particularly burdened by COVID-19, so that we're getting right to those that need it most as quickly as possible.
Next question.
From Sarah Levitt, CBC. Please go ahead.
Hi, thank you very much. Wondering, when we look at distribution, of course, the vulnerable population is a huge consideration in the prioritization. How much is the decision based around areas that are perhaps vulnerable? So, for example, like Brampton, which is currently a hotspot.
So I'll jump in. It's Dirk. So thank you for that question. Another example of something that is a significant consideration where there is a greater burden of illness. So where there are more cases, such as Brampton, Toronto, York, Windsor, Essex, all of those are areas, and there are others, of course, but those are those ones that have been particularly affected right now, Brampton being part of Peel. So yes, that is a consideration, and we will use that as one of the many factors of deciding it goes back to that what I was talking about as far as a regional approach. So there's a population, so the population of long-term care residents, staff, and retirement home residents and staff, and vulnerable seniors, residents and staff. So take that as the vulnerable seniors who are living in congregate care where care is provided for seniors. That would be the population. Then thinking within that population, one of the key factors, or one of the factors, doesn't mean it's the key, would be the area where, and understanding the extent of the infection within an area. So it's taking that population and then another factor within the population that's regionally specific.
If I could,
Yes, please,
add
Dr.
to
Yaffe.
that, yeah, thank you. The first distribution of the Pfizer vaccine has been through a select number of hospitals due to the requirement to keep the vaccine at an extremely low temperature. However, the vast amount of immunization will be planned and coordinated through the local public health units. And the local public health units have a very good sense of what's going on in their community. They'll be working collaboratively, obviously, with other parts of the healthcare system, hospitals, physicians, community health centers, paramedics, and so on. And so they will, within the framework set by the province for prioritization, they will be directing vaccine to the most risky within that priority group. So that is built into it from a local delivery point of view.
Follow up?
I'm just going to add one quick thing to that. That's an excellent addition, Dr. Yaffe, and frankly, it fits exactly into what we've been thinking about in the approach to prioritization, which is the public health units have the regional knowledge, they have the expertise, they are vaccine experts. They have been doing this for years, and they, in fact, will apply the prioritization at the regional level based upon, as Dr. Yaffe said, from the provincial framework, and because they know, not only do they know their own region, they'll work together with the hospitals, they'll work together with Ontario Health, they'll work together with the other community leaders to figure out how to best provide that within the local areas. Thanks, Dr. Yaffe.
Follow up?
Yeah, so we're always hearing when it comes to vaccine priority, the most vulnerable first, that being the most important thing in this prioritization. Now, I don't know, maybe this is a question for Dr. Yaffe, but we haven't actually seen the most vulnerable vaccinated yet in Ontario, long-term care residents. And I know that it's been said before that it's the complications around moving the Pfizer vaccine because of it needing that cold conditions. And yet Quebec, for example, got the vaccine at the same time as us, and they got it delivered directly to the long-term care homes. So I know it's coming, but what's the reasoning for it taking until the Moderna vaccine to get the vaccines to the long-term care residents?
We have started with the people who work in long-term care and essential caregivers, and not only because of the Pfizer vaccine logistics around its storage and transportation, but also our experience has been that outbreaks in long-term care tend to be introduced by workers, obviously not for their own fault, but because they are people who live in the community. And if they're in a community with a lot of transmission, they can then bring it into the facility. So one of the most important ways of reaching long-term care homes is through the workers to help prevent transmission into the home. We are starting now that Moderna's coming today, I believe. We are going to start offering vaccination with Moderna to residents of long-term care and high-risk retirement homes this week. So we're doing it as soon as we can with Moderna, at the same time continuing to reach the workers and the essential caregivers.
Next question.
From Darren Boland at Global News Radio 640 Toronto.
Good afternoon, everyone. Thank you very much for taking my call. These questions are on behalf of my colleagues at Global News Toronto. My first question is a two-parter. How much oversight is the Ministry of Long-Term Care providing to homes experiencing outbreaks, and what is being done to ensure proper staffing levels at homes with extreme outbreaks are being maintained?
Well, obviously, none of us are with the Ministry of Long-Term Care here, but I am on the long-term care IMS table. The Ministry of Long-Term Care is very closely involved in monitoring all the outbreaks and working very closely with Ontario Health and bringing in management orders and bringing in hospitals to help, for example, with tender care, which I have been involved with, and bringing in other facilities, as well as just having set up a specialized care center through the Grace Hospital for offloading patients from long-term care as needed. So they're very closely working on that situation. It's obviously very high priority, very high vulnerable population.
Follow-up?
Thank you for that answer, Dr. Yaffe. And my follow-up would be, what is the breaking point into which the province would suggest military intervention? Has this been recommended to decision makers?
I can't really answer what the breaking point is. Certainly it's a consideration, as is, bring in potentially Canadian Red Cross, which has offered its services, and depending on what the needs are, has been taken up. So these are all considerations. I can't tell you the exact breaking point.
Next question.
From Alex Boyd, Toronto Sun. Please go ahead.
Hi, guys. Thanks for taking questions. I just have a question about what transparency means in practice. You've spoken about the link between communication and trust from the public, but right now Ontario is only reporting the number of doses administered, I believe, on a weekly basis. Will we see more transparency for the public in terms of who is getting these shots? I know some American jurisdictions are even breaking it down by, geography, age, race, and ethnic background. Is that something we could see, something we should see?
So I'll respond to that. And at this particular point, we are increasing the frequency of vaccine reporting, I believe, over the next number of days. The specifics as to the individual subtypes, I honestly don't have the knowledge right now exactly what will be occurring with that. So unfortunately, I don't have a specific answer for you, but the numbers, we have been, and I believe we are going to move towards reporting every day.
Follow-up?
Sure. And yeah, just to stay on the transparency piece, I know a lot of this is being decided as we go, given the uncertainty around approvals and transportation. But as you guys start to make decisions about who will be prioritized, how is this going to be communicated to the public? How far in advance will they know specifically if they're in line? How will they know when it's their turn?
Now, those are great questions, and thank you for asking those. So that is work that we are actively engaged with at the prioritization subgroup, having those conversations, thinking about which populations will be sequenced in what particular phase and over what time frame. And we're hoping to sort through those over the next number of weeks and have that information publicly released is the understanding that I think we are working towards so that people have an understanding where they will be, what group they would be. It won't be down to the individual level of when Dr. Smith is going to get his vaccine or when Dr. Huyer will get his vaccine or Dr. Yaffe, but it will be the populations and the areas that you would fit in. And then within those populations, as I talked about in the healthcare workers, will need to be, again, sub-prioritization, thinking through the greater risk that one person in that population may have with the other. So there is a fair bit of logistics that will be required within. As the number of vaccines increase, the availability will increase, the speed will move forward, and the populations will be provided vaccines, offered vaccines in a more rapid process. We know that Pfizer's been approved by Canada. We know Moderna's been approved by Canada. Both of those happen fairly quickly after each other, and others are being looked at, as is my understanding.
Last question.
Will be from Mike Walker, CTV Toronto. Please go ahead. Please unmute your line, Mike.
There we go. Thank you for taking my question. Just following up on a question my colleagues had asked earlier about paramedics. I know you mentioned that the expectation is that they will receive the vaccine in March. What needs to happen in order for that to happen? And is it possible that they may have to wait until the second phase?
So the anticipation is that they are part of the first phase.
Follow up, and this is the last question.
And just two parts to that. What needs to happen so that the vaccine will be available for them by March? And secondly, what about other first responders like firefighters who are also expressing some concerns? When can they anticipate to be a priority?
Now, these are all questions that we're working through with the prioritization group. Will be defined by a number of different things based upon the risk levels that will be identified. We have, in Ontario, identified 4 groups, and those 4 groups have been publicly released, and those are the ones that we are working together, all of us across the vaccine distribution and the vaccine administration areas, public health units, hospitals, many different professionals, to provide the vaccine in the most efficient and most equitable way over the first number of months, and healthcare workers were one of those groups that were included. Others will be worked on through discussions, and hopefully over the next coming weeks there will be further clarification of all of the different groups based upon the discussions that we have flowing from potential risk, flowing through the ethical framework that's applied and utilized and informs all of the discussions. Those discussions will then be brought to the task force for consideration, and as those decisions are made, I anticipate they'll be released publicly.
Thanks, everyone.
Thank you, Dr. Smith. Dr. Yaffe.
Thank you.
Thank you.